Good afternoon, everyone. These are my disclosures. So in the next few minutes, I'll be talking about the comparative effectiveness of opioid versus opioid-free analgesia after surgery. And the main message that I like to deliver is that, there is very limited evidence supporting the prescription of opioids after post-operative hospital discharge. And before I start, I would just like to specify that this presentation will focus only on outpatient post-operative analgesia, with very limited attention to analgesia delivered during hospital stay. So, as you probably can already recognize from my accent, I am not from North America, but I have been living in Montreal, Canada for a while now. There, I work with a proudly multi-international team of scientists and clinician scientists coming from several parts of the world. And when the impact of the opioid crisis started making the headlines of all our major surgical journals, our international team members got really intrigued. A very common reaction. What is happening here? Surgeons back home rarely prescribe opioids, especially after hospital discharge. And the literature actually also supports this impression, as it has shown huge discrepancies in opioid prescribing, especially between the US and other countries in Europe, Asia, and South America. As you can see from this table here, in the US, we're talking about over 80% of patients receiving an opioid prescription after surgical discharge, in comparison to less than 5% in other parts of the world. But one question that may come to your mind when hearing about these differences in prescribing culture is standards of care seem to be very different in the US and Canada in comparison to other countries. So maybe our patients need opioids more than others. This actually may be true. Research supports that post-operative length of stay is generally shorter in the US and in Canada, and our rates of outpatient surgery are among the highest in the world. And of course, with earlier hospital discharge, patients may be at greater risk of feeling pain and discomfort at home. However, the need to prescribe opioids for these patients should not be simply assumed. It should be supported by evidence. So speaking about evidence, what is the current evidence regarding the benefits of opioid analgesia after post-operative discharge? The results that I'll present right now come from an extensive scoping review of the literature that we conducted to map the literature on opioid-free analgesia after surgery. And as you can imagine, this review was quite big. We screened almost 60,000 abstracts and identified 392 studies describing opioid-free analgesia strategies. And there are two main findings from this review that I would like to call your attention to. In my opinion, the most striking finding was the low number of studies on opioid-free analgesia conducted in North America, with only 1% of the studies coming from Canada and 2% of the studies coming from the United States. And also very importantly, only 42 studies, around 10%, addressed opioid-free interventions after hospital discharge. Of these studies, 7 were RCTs comparing opioid versus opioid-free analgesia. 3 of these RCTs involved outpatient surgery, and 4 involved inpatient surgery. So now just taking a closer look at the outpatient surgery trials. All the studies involved at least some patients undergoing abdominal surgery. Only 1 study was conducted in North America. It's a study from Canada. And in terms of results, as you can see highlighted in yellow, none of the studies showed differences in pain outcomes when comparing patients who received opioids in comparison to patients who did not receive opioids. And as highlighted in red, 2 of the 3 studies showed increased adverse events with the use of opioids, and 1 study even showed decreased satisfaction with pain control in patients in the opioid group. Now a closer look at the RCTs involving inpatient surgery. Unfortunately, only 1 study involved abdominal surgery. Again, only 1 study was conducted in North America. And in terms of results, again, none of the studies showed differences in pain outcomes when using opioids or using opioid-free analgesia. And most of the studies also showed increased adverse events when using post-operative opioids. So in summary, what this scoping review showed is that existing literature does not support the superiority of prescribing opioids versus opioid-free analgesia after post-operative discharge. But when analyzing these results, there are some things that we should bear in mind. Most of the studies were conducted outside the US and Canada, so they may not reflect standard practice in these countries. And also, the results that I just presented, they were extracted for a scoping review without waiving risk of bias or evaluating heterogeneity to support meta-analysis. And this is actually what we are working on right now in a follow-up project. So our current scenario, evidence supporting the prescription of opioids after discharge is very limited. However, this practice is still heavily ingrained in our healthcare culture. So you may ask, on the short term, why we wait for further evidence? What can be done to reduce opioid-related harms in my clinical practice? So I'll give you 3 ideas that have been recently proposed in the literature. Of course, the first one would be to follow current guidelines for opioid prescribing. In the last 2 years, several guidelines have been proposed in the literature, including 4 examples here on the screen, but there might be even more. And these guidelines, they are referred to as evidence-based, not in terms of comparative effectiveness, but in terms of how much opioids patients actually use after specific surgical procedures. So these are the recommendations for frequent prevalent abdominal surgeries. And as you can see, there are not huge differences between the recommendations coming from different guidelines. And the standard recommendations usually target the prescription of 8 to 15 opioid pills for MIS surgeries. Also importantly, most of the guidelines also consider the option of not prescribing any opioids for selected patients. And when these consensus recommendations were applied in practice, the literature support excellent results in terms of reducing the amount of opioid prescribed and also without increasing the need for opioid refills. The second idea that I'd like to share is encouraging patients to fill their opioid prescription only if needed, instead of having opioid pills sitting at home even when they're not required. This idea was proposed in a very interesting study published this year by a group of fellow Canadians from London, Ontario. So in this study, for post-operative analgesia, patients were prescribed NSAIDs and acetaminophen around the clock, and tramadol or codeine PRN in case of breakthrough pain. As I mentioned, what I found most interesting is that they instructed patients to fill their opioid prescription only if they had uncontrolled pain. Using this multimodal approach, the authors reported improved quality of pain control and also improvement in some functional measures. And most importantly, the authors observed a reduction of over 50% in the number of opioids prescription filled. And even patients who ended up filling their prescription, the patients who were in the intervention group, only a minority did it because they required opioids for additional pain control. So through this very simple idea, this study supports that encouraging patients to fill opioid prescription only if needed may be a viable strategy to decrease opioid-related harms after surgery by reducing the amount of excessive opioids available in the community. And finally, the third suggestion that I like to share is being ultra-restrictive in your prescriptions. And this idea is based on this study on gynecological patients published on JAMA Open last year. And in this study, post-operative pain management was slightly different for different patient groups. As you can see here, for patients undergoing ambulatory or MIS surgery, only ibuprofen and acetaminophen were prescribed after hospital discharge with no prescription of opioids whatsoever. And patients that are going laparotomy had, in addition to ibuprofen and acetaminophen, they had a prescription of opioid supply for 3 days, the equivalent of 12 tablets. So this ultra-restrictive protocol was not detrimental in terms of pain, opioid refills, or post-operative complications. And of course, the intervention considerably decreased the number of opioid tablets prescribed to patients. So if you're an MIS surgeon, following this protocol would mean not prescribing opioids for the great majority of your patients. Does this sound crazy? Maybe. But the literature and actually also international experiences support that opioid-free analgesia may be feasible for this specific patient population. So just finalizing, regardless of the approach that you choose to reduce opioid-related harm in your practice, it's important to keep in mind the importance of preoperative patient counseling, especially in terms of pain expectations. And I invite you to visit the webpage of the Open Initiative, as they have very interesting material about patient education. And also importantly, we cannot talk about opioid-free analgesia or reducing opioid harms without considering multimodal analgesia, including regional analgesia, acetaminophen, NSAIDs, and other non-opioid drugs. And this topic will be covered in several of the presentations this afternoon. So, in conclusion, although opioids are the mainstay treatment for post-operative pain in the US and Canada, evidence regarding the comparative effectiveness of opioid versus opioid-free analgesia is still lacking. And I could not emphasize more that post-operative opioid prescribing should be guided by science rather than by tradition and dogma. Thank you.